espasmo sintomático después de una hemorragia subaracnoidea aneurismática. Doctor, bienvenido.
Thank you, Carolina. It is my pleasure to see you all. We welcome all of our friends from around the world to be with us here today. We have a very special lecture today. As many of you know, I'm very interested throughout my career in bypass surgery to the brain. It has been a big area for me personally. So this is a very special lecture. We have a speaker with us today, Professor Asahikawa, perhaps one of the most experienced people on planet Earth in doing bypass surgery. We have known, we've been friends for many years. I respect him for the master surgeon that he is in a very difficult specialty of neurosurgery. In doing bypass surgery, his work has been pioneering work in the field of vascular neurosurgery. He has really advanced the techniques that we have available for doing extracranial to intracranial bypass and the techniques of doing actual microanastomosis. So it is just a personal honor for me to really introduce the professor here. It is obviously morning time in Japan, Saturday morning now. And Professor, it's great to have you with us.
Thank you, Salim. Thank you very much. I'm very glad to be here. It is a great honor to share my experience here with Salim, everybody, and especially this time. This is for mainly for neurosurgeon in U.S. and Mexico, Latin America.
No, we have people from around the world, so there'll be people
around the world,
from Europe and other places as well.
Okay. Anyway, it's my pleasure to share my experience in neurosurgery with all the neurosurgeons in all over the world. Yeah, thank you very much. And I'll share my screen here. Can you see this?
Yes.
Okay. Today's my topic is vascular reconstruction, and additionally, I'd like to talk about the prevention of a symptomatic vasospasm after subarachnoid hemorrhage. I always ask myself, and I always ask my young colleagues, what is the accuracy in surgery? What is accurate surgery? This is very important. Everybody knows confirmation of the anatomy in the operative field is very important. And mainly this is a most important part in the surgery. And this means that this means to expose the object in the operative field with a clean condition. To do a clean condition, we need no blood operative field. Hemostasis is quite important, very important. And everybody knows the essentials in neurosurgery is the following. Again, hemostasis, dissection, especially in neurosurgery, there are two major approaches, Sylvian Fisher dissection, interhemispheric dissection. Relatively, interhemispheric dissection is difficult, but these two approaches is a fundamental approach to perform the safe surgery, especially aneurysm surgery. Not only aneurysm, but also tumors the like a meningium or something. And in a late part of the surgery, the dural closure it's problematic. If the dural closure was not good, always the fluid correction happened after surgery, and the CSF contains sugar, blood sugar, and if the CSF correction happened, it may be a good culture material of the bacteria after surgery. If the patient have the bad metabolic condition like diabetes mellitus something, the easily happens infection after surgery, and such an infection may change the patient prognosis worstly. So the dural closure is very important. And additionally, if necessary, we have to, or we can perform the microvascular anastomosis. Not only bypass, but also arterial or venous repairing during surgery. So these kind of factors in surgery are quite important. We need to master everything in every step in life as a neurosurgeon. This is an example of a complete hemostasis before opening dura. This is the right side front temporal craniotomy. Now, the front temporal craniotomy is performed, and I am doing a complete hemostasis before opening dura. Not only dural surface, but also breathing from the space between the skull and the dura, using cautery or Sagittal, and then you can open the dura. No red cell should be on the dural surface in the operative field. Then we can approach to the aneurysm. This is another example of a middle fossa dissection. If we perform the dural elevation from middle fossa, breathing come from not only cavernous sinus, but also from a bony surface. But every hemostasis enables you to visualize the important anatomy like this, to recognize the anatomy in the middle fossa. This is the almost final view of a middle fossa dissection. We need to recognize V3, foramen ovale, GSPN, and arcade eminence covering the super semicircular canal, and the P+H, GSPN. This part can consist the temporal rhomboid, and then we can drill there. And by drilling the temporal rhomboid, you can expose the C6 carotid, the IAC, and we can preserve the semicircular canals and the cochlea, not to injure anything. Anyway, the hemostasis is very important to recognize the anatomy. And as I mentioned, dural closure is quite important. This is a dural closure using a 6-0 proline, 5-0 proline under microscope. In my institute, I force my young guys to use the microscope to close the dura like this, to perform the complete dural closure and penetrate the whole dural layer. The penetrating whole dural layer is very important. If I'll show you next slide, when we perform the microvascular anastomosis, whole layer penetrating is important. It must. So in a drawing, I can explain the penetrating dura like this. And if the thickness of the dura was like this, the T, the stitching bite should be twice of the thickness, 2 times of dural thickness, and the interval should be 4 times of dural thickness. And you can stitch the dura with square stitch. This is very important to avoid the CSF leakage in between the intervals of stitches. As well, the same principle can be adapted to a microanastomosis. And I always emphasize to have a successful result of the microanastomosis, we need everything of the each vessel wall, donor and recipient. If you perform the everting technique like this, it's easy to penetrate whole layer in each vessel wall. Additionally, I would like to emphasize that if when we perform the end-to-side anastomosis, the end of donor should be trimmed like this. It is so-called mouth trimming, and 60-degree oblique cut, and same length cutting up in the other side. And the stitching length can be calculated like this. If you cut the 60-degree oblique cutting, the whole length of the stitching length should be 2.3 times of the large D. Large D means the shrunk diameter of the donor. It is the basic dimension to perform the fish mouth trimming, and we can understand the stitching, the suturing length is around 2.3 times of the diameter of the donor. And in microvascular anastomosis, if each vessel wall can be adapted like this, we can easily penetrate the vessel wall, and stitching bite should be twice of the wall thickness, and the interval should be 4 times of wall thickness. Then we can have the complete stitching, sewing of the vessel wall. This is a drawing by my colleague Cosmo Noda. The principle to perform the microanastomosis like this. And this is a drawing by my mentor, Professor Kamiyama. It's around 40 years ago. He drawn these pictures. When we perform the side-to-side anastomosis, he taught me the arteriotomy should be symmetrically, slightly curved the inner side like this, and then you can make the orifice bigger. And bottom side stitching should be like this from the inside of the vessel. Otherwise, you can't stitch the bottom side vessel wall. And upper side vessel wall can be stitched with interrupted. If you like, you can do a running suture as well. Anyway, this is a basic technique of the side-to-side anastomosis. But you may realize that in the bottom side suturing, the vessel wall is attaching not everting. This is inverting, you see? So the cutting edge of the vessel wall in the bottom side is facing inside of a lumen, And this means that the collagen fiber at the cutting edge of the vessel wall is exposed inside the vessel lumen. And this may causes something acute thrombosis of the bypass after reflow. So to avoid such a complication, we need a big orifice. This is the reason why Professor Kamiyama taught us you should make the not linear incision, not a straight linear incision. You should make the curved arteriotomy like this. And at least we need arteriotomy more than 3 times of the apparent artery diameter. This can prevent acute thrombotic occlusion of the side-to-side anastomosis. Everybody knows if you fail the side-to-side anastomosis, you lose 2 vessels, 2 arteries. This is a big problem. So we have to realize it. And next, I'll show you the basic approach, transluminant approach. This is a 57-year-old man and ruptured PCOM aneurysm. This is a surgery around 10 years ago. This is a transluminant approach with the highest magnification to expose the M2, M3 segment, and I am dissecting the proximal part of a sylvian fissure. And this is an anterior temporal artery attaching to an inner surface of a temporal lobe. And you can see the aneurysm attaching to the uncus. And here is the branches from anterior choroidal artery attaching to the uncus. Here is the inlet of the ambient cistern between the carotid and the uncus. By detaching the trabeculus from carotid, you can retract the uncus posteriorly, and in the depth you can see that is the oculomotor nerve. And the arachnoid trabeculus between oculomotor and the uncus can be cut, and you can secure the operative field in a retrocarotid space. Now I'm confirming the PCOM and anterolateral perforating artery arising from a very proximal of the PCOM. This is a very important confirmation to avoid the occlusion of anterolateral perforating artery. Preserving PCOM trunk is relatively easy, but the preserving such the small branches, especially which is arising from a very proximal PCOM at the near neck, is not easy. To see is not easy. So to see, to recognize such an important structure is quite important during surgery. How to do such an important situation? I'll show you an example of a retrograde suction decompression through suprathyroid artery during surgery. This is a 50-year-old female compressing the left optic nerve, and I'm inserting a 5 French infantile feeding tube in suprathyroid artery after opening neck, and the tip of a tube should be placed in a common carotid artery, and this tube is fixed with a suturing, and before attacking the aneurysm, this is a backup bypass as a STA M3 bypass, M4 bypass on the temporal surface with a tin zero suture. I am making the end-to-side anastomosis as a STA MCA bypass. And then now the aneurysm is exposed. The internal carotid artery distal to the aneurysm is clamped with a temporal clip. And the external carotid and the common carotid is occluded. And through the suprathyroid cannulation, the assistant can suck the blood. Then you can have the retrograde suction decompression and easily decompress the left optic nerve like this. And you can make the space between the aneurysm and the optic nerve. And this is expanded distal drawing. This should be inside to expose the neck completely. Here is a superior part of a super optic sheath and the distal drawing superior part. And here, you can expose the proximal neck and the distal neck completely. And I am placing the neck clipping like this, and almost the aneurysm is dead. But with very strong atherosclerosis on the aneurysm neck and the aneurysm dome, you can see it, the plaque in the aneurysm neck, aneurysm dome, and this aneurysm has a partial thrombosis. So I am removing the thrombus inside, but you can see the slight arterial bleeding is coming, still alive. So I am adding a fenestrated clip to close the thin part in the medial neck, medial dome. And I am trying to occlude the aneurysm completely. Now, after the thrombectomy, we can confirm whether aneurysm is really dead or not. And the CT angio shows a very good condition of the internal carotid and the intracranial arteries. The patient recovered well. So the retrograde suction decompression is quite useful to decompress the aneurysm safely. Another case, this is a 36-year-old female kissing aneurysm, PCOM and anterochoroidal artery aneurysm is kissing like this. At this moment, I realize that this is quite difficult to safely detach each aneurysm. So again, suprathyroid artery cannulated, put a temporal clip on intracranial carotid distal to the aneurysm, and a PCOM is occluded, and the common carotid is occluded, external carotid occluded, then retrograde suction decompression. And partially I injured the PCOM wall, but safely both aneurysms could be detached. And this is a choroidal artery. I am preserving it with a neck clipping. And this is the remaining PCOM aneurysm attaching to an oculomotor and a tentorium, relatively larger than a choroidal artery aneurysm. And again, the anterior term perforating artery is very attaching to the neck. This should be confirmed and detached to perform the complete neck clipping. Then post-operative CT angio shows a good occlusion, good condition of intracranial artery. Again, another case. Now my young colleague is operating, that I advised him not to put a clip in this situation and not to put a clip on the supracranial carotid because of a hard atherosclerotic change, but he wanted to do this. And premature rupture happened. Even the temporal clipping on supracranial carotid, the PCOM is a fetal type, and so we need the temporary, the trapping is necessary to control the breathing, and I immediately scrubbed in and confirming. This kind of manipulation is very dangerous. Without the sufficient operative field of the preparation, you may easily make this kind of complication, the neck laceration. This is a neck laceration, and it must be repaired with a direct stitch with a 10-0 suture like this. And then you can make the neck clipping. But my main concern is not this. Main concern is the strong atherosclerotic change. And unfortunately, my expectation was true. That you can see the PCOM was occluded because of the temporal occlusion of the very hard sclerotic part. And I am irrigating inside the carotid and the PCOM and check the reflow after irrigating inside. And you can see the breathing comes. So this means that the occlusion of the PCOM origin could be repaired. And again, I confirm the after reflowing carotid, and the ICG green shows the good patency of a PCOM and everything, choroidal artery. Now, the CT angio immediately after surgery, but the PCOM occluded. So immediately I transfer the patient OR again. The diffusion image, the high signal in the medial temporal lobe, and the PCOM was occluded completely. I decided to perform the emergency PCOM, STA PCOM bypass, like this, through the transribbian route. Then I could secure the PCOM with the STA, and we could limit the infarction in the medial temporal lobe. So this is a good teacher for us. Not to put the temporal grip on the hard sclerotic part of the internal carotid. Open the neck and make the sufficient operative field, sufficient preparation before applying the clips to the aneurysm. This is a very important teacher for us. Fortunately, just after the surgery, patient had a hemiparesis because of the anterior term perforating infarction in thalamus, but recovered well. Around 2-3 weeks later, patient discharged without support. Anyway, this is very important. So this technique, retrograde suction decompression during neck clipping for complex aneurysm or difficult aneurysm, we have already published on the World Neurosurgery. You can find it. Another example, I'll show you an anterotemporal approach. This is a 75-year-old female, the unruptured right side superior cerebral artery aneurysm, relatively high position. This is a right side front temporal craniotomy. Before front temporal craniotomy, the transzygomatic approach is performed. And again, the complete hemostasis of dura, and then the transribbian anterotemporal approach is performed. And sphenoparietal sinus is stretched. Then it is detached from the inner surface of the dura and release the tension. And then you can approach to the aneurysm. This is the right superior cerebral artery. I'm confirming the basal trunk where it can be clipped as a proximal control. And that is a contralateral PCA. And I am detaching the important perforator behind the aneurysm. And this is a distal neck between the aneurysm and PCA. With this condition, we can see everything, especially a very important perforator here. I'm confirming whether that perforator is preserved or not. And the superior cerebellar right PCA is confirmed with the Doppler sound. This is a CT angio, and this is a drawing by my colleague, what we did, like this. Another case, 84-year-old female ruptured basal aneurysm, large one. At the onset, patient was grade 5, Hunt and Cosney grade 5, but one day later, patient recovered, and then we had a very big discussion with the patient family, and strongly patient family hoped to undergo surgery. So I decided to perform the clipping through the epidural anterotemporal approach as a transcavernous approach by opening the oculomotor foramen because the subarachnoid clot was less, very less. So just expose the aneurysm in a very short time because of the very elderly patient. Now the basilar trunk and the contralateral SCA and ipsilateral PCA is occluded, ipsilateral SCA as well. And here, this is a right side post-term perforating artery attaching on the neck. Aneurysm is big. Here is a posterior surface of the aneurysm and important perforator rising basilar bifurcation in interpeduncular cistern. And here, this is a contralateral, the small vessels and veins. But fortunately, everything could be detached from the aneurysm neck. And a large straight clip could be applied. And confirming the other side tip of a clip blade. And this is the right side clip blade. And the clip blade is anchoring something, connective tissue, arachnoid trabecular something, which was connecting to the post-term perforating artery, contralateral one. And I detached it. And the tiny PCOM is cut after cautery. And additional clipping is added. And I have a still doubt of the aneurysm still alive. So I am confirming because the aneurysm is embedded in third ventricular floor. I am detaching it and putting it, and now the rupture point is open, and no bleeding come, and I could confirm aneurysm is dead. And everything is removed, temporal clip is removed, and the IC green shows all the perforator were preserved. Contralateral one, ipsilateral one. This is a final view. Like this, the aneurysm is completely occluded. The patient recovered. Because of a very elderly patient, before subarachnoid hemorrhage, patient had a support to walk. So with the same condition, patient discharged. I'll show you STMC bypass of complex aneurysm and direct reconstruction of the Fuchs-form M1 aneurysm. This is a 45-year-old female. She is a gynecologist, and she's very young. So we need a complete reconstruction of the middle cerebral artery aneurysm after resection of a the MCA aneurysm. Now, the right side translabelin approach, and I am performing the double barrel STA M2 bypass. This is the first bypass for inferior trunk of M2. Like this. And so you can confirm the bypass is open. And this is the super trunk of M2. Another branch of STA can be anastomosed. Now, the bypass is finished, and the basic preparation to attack the aneurysm is completed. Then the aneurysm can be exposed. And the main concern in this case is where the lenticular artery is arising. In this case, we can confirm the lenticular artery was arising from the distal M1. You can see it. And the proximal M1, no lenticular artery. So I could understand we can resect the aneurysm by a trapping. And this is a proximal end, and here is a distal end of the aneurysm. It can be incised and removed. Because of the redundant of M1, it was easy to make the direct stitching as an end-to-end anastomosis. In each end of the M1, I made a fishmouth trimming upside down in each side. Then you can make the end-to-end anastomosis orifice bigger because you can realize the arterial condition in both vessel wall is not good because of atherosclerotic change. So we need a big orifice to have a long-term patency. And icy green shows a good re-anastomosis of M1 segment, and lenticular straight artery from a distal M1 is preserved. And this is the final view, and the MRI scan shows no new lesion. And this is a CT angio. This is the illustration what we did. After the STA-MCA double barrel bypass, we can make the end-to-end re-anastomosis. You know, after the revascularization by STA, we have no time limit to reconstruct the end-to-end anastomosis at M1. It is safe. Just a meticulous, exact stitching is necessary to have a successful reanastomosis. Next case, high flow bypass, 49-year-old female, ruptured one, the so-called blood blister aneurysm. Blood blister. We usually perform the high flow bypass using a saphenous or radial artery for blood blister aneurysm. Now, after completing high flow bypass, I am confirming the rupture point at the supracranial carotid. This is the right side, you can see. Now, the breathing calm. Now the ICA is occluded in the neck, and temporal clip is placed distal to the aneurysm and proximal to the aneurysm rupture point. Now you can open the high flow bypass. And this is a confirmation of anatomy because the rupture point was just the opposite side of a PCOM orifice and the corridor arteries. To preserve the PCOM and the corridor artery, the clip is obliquely placed to preserve the PCOM with anterograde flow, and the corridor artery flow should be preserved by retrograde flow from the high flow bypass. Anyway, like this, with high flow bypass, aneurysm can be trapped and patient recovered well. Even subarachnoid hemorrhage in acute stage surgery, we can perform the high flow bypass. So in conclusion, clean and bright operative field is necessary, hemostasis in every step, highest magnification to see tiny structures. Only arachnoid membrane can be cut. Not only arteries, but also veins must be preserved. Distal cerebral separation between frontal and temporal lobe is a basis of a microsurgery, especially of a microanastomosis. Watertight dural closure is a good training to perform microanastomosis. This is a principle in cerebrovascular surgery. And we can discuss how to prevent DIND after subarachnoid hemorrhage. This is a very important. It is said that the delayed ischemic neurological deficit due to symptomatic vasospasm is the most important factor of poor outcome after aneurysmal subarachnoid hemorrhage. We have many reports previously, and still now it's a big problem. Now, it is said symptomatic vasospasm rate around 10 to 30% in many literatures. Mortality rate is higher in coiling group in a high-grade subarachnoid hemorrhage. So everybody knows thicker clots, more symptomatic vasospasm. This is our paper published in 2017 on world neurosurgery. We can prevent the symptomatic vasospasm with meticulous clot removal and continuous low dose intravenous nicotine administration. And another paper we published in 2015, my colleague Dr. Ota, Dr. Matsukawa. CLEAN means a continuous low dose intravenous nicotine administration. We have two groups, continuous low dose nicotine group and no nicotine group. And in the nicotine group, symptomatic vasospasm rate was less than 3% at the 2015. The non-nicotine group have the around 14% of symptomatic vasospasm. This is our result in this 25 years. And this is an analysis of this paper. And the multivariate logistic regression analysis for the symptomatic cerebral vasospasm, continuous low dose intravenous nicotine was significant to avoid the symptomatic vasospasm. Yeah, like this. So the treatment protocol for subarachnoid hemorrhage in our hospital is like this. Patient must be transferred to OR within 1 hour after the arrival to the ER. We do ultra early intervention, the surgical clipping first, the aggressive clot removal for all approachable cistern, no cisternal or spinal drainage after surgery, no triple H therapy, normal volumic CVP should be maintained around 5 to 12 centimeter during 2 weeks after surgery. And the important protocol is the irrigation and the removal of subarachnoid clot with using high pressure irrigation suction system developed by Professor Kamiyama 40 years ago. And using irrigation solution, saline with urokinase 60,000 international unit in 5 milliliter saline. With this solution, we can rinse the subarachnoid clot at the beginning of the micro approach, and then the subarachnoid clot can be removed very well. This is an example of a subarachnoid hemorrhage, ruptured PCOM aneurysm, the very thick clot in bilateral sylvian and pentagon. And this is a right side approach with a double suction. Left hand had the irrigation suction system, irrigating the cistern with urokinase saline, and the right side simple cycle is removing the clot, the irrigate and the sucking, irrigate and sucking, and then you can expose the aneurysm like this. In this case, to control the proximal, I remove the anterocrinoid process to expose the supracrinoid carotid. And this is a difficult aneurysm because of that. Even this is a PCOM aneurysm, but this is a medial projecting and a very wide neck and a very hard atherosclerotic change. This is the operation around 10 years ago. So now I don't put the temporary clip on the supracrinoid carotid, which has a very strong plaque, as I mentioned before. But the 10 years ago, I at the time I still use a temporary clip on the hard atherosclerotic change. Anyway, after clipping, the contralateral sylvian fissure clot is evacuated meticulously rinsing, and this is a prepontine cistern that I am irrigating inside of the prepontine and the interpeduncular and the so you can see the CT shows the well removed the subarachnoid clot, and we can prevent a symptomatic vasospasm. Another case. This is a very thin subarachnoid hemorrhage. This is a relatively large frontotemporal parietal craniotomy. And you can see here, this is the aneurysm. This is a PCOM aneurysm. Like this, the irrigation, with the irrigation suction system, the urokinase saline is flushing the subarachnoid clot like this, and you can expose the aneurysm and the microstructures. You can see it clearly. You can see it. And tentative trapping, aneurysm can be shrunk. And now aneurysm is rupture point is opened. You can see here, this is important perforators from a PCOM, very proximal part. And all the anterolateral perforating artery is preserved and the aneurysm completely clipped. Here again, you can confirm all the structure. The icy green shows all the anterolateral perforating artery, PCOM, choroidal preserved like this. So the rinsing the subarachnoid clot is very effective. This is a 62-year-old female, ACOM ruptured large one. This is a bifrontal craniotomy for anterior interhemisphere approach. Now, this is a olfactory nerve. Before separating interhemisphere fissure, the olfactory cistern is opened and the olfactory bulb should be fixed to a dura with a fibrin glue gel form. And now the interhemisphere fissure is separating with the frequent irrigation of subarachnoid clot with irrigation suction system. And aneurysm can be clipped completely. Icy green. As well, additionally, we remove the bilateral Sylvian clot through the front basal approach and irrigate the subarachnoid clot in Sylvian fissure. And this is a carotid cistern opened. The carotid optical carotid space is opened, irrigate in a peripontine cistern. Every approachable cistern should be rinsed and evacuate the subarachnoid clot. This is the left side. And tiny aneurysm was found, so I clipped. Anyway, this is the left side optical carotid space. Again, irrigate inside. Now, this is a pre-operative CT and the before. We can compare it. And with this meticulous clot irrigation, we can prevent the symptomatic vasospasm. I think time is limited. I can skip. If the clot was remained like this after surgery, this was after surgery, after clipping of ACOM through the interhemisphere approach. In this case, we didn't take the bilateral Sylvian clot after clipping. So in this case, patient have the symptomatic vasospasm. Day 1, MRA shows like this. Day 7, like this. Day 10, you can see the severe symptomatic vasospasm happened. Oh, sorry. Like this. Day by day, the vessel has a symptomatic, the severe vasospasm, and the patient have the very big infarction. To avoid such a complication, we want to take out the subarachnoid clot as much as possible. This is our newest data with a 278 subarachnoid hemorrhage from 2012 to 2019. And symptomatic vasospasm rate was 5.1%. And infarction was happened in 4%. The prognosis outcome was modified ranking scale 0 to 2 was 75%. More than 3 modified ranking scale was 24%. Univariate analysis shows us age and WFNS grade was a significant factor of symptomatic vasospasm and a poor outcome. And multivariate analysis shows age and grade was a significant factor to have the symptomatic vasospasm. These are the cases of symptomatic vasospasm. The relatively very elderly patient, like this. The multivariate analysis for poor outcome is age, grade, and some other factors, anticoagulants like warfarin something or clopidogrel or something, and the hyperlipidemia. Of course, DIND happened. It's a bad factor of a poor outcome. So in general, it is said symptomatic vasospasm rate is higher in a young patient, around less than 50 years old. But in our series, our symptomatic vasospasm patient are almost 70 years old, more than almost 70 years old. And cerebral infarction in our symptomatic vasospasm was quite low, around 4%. And many of them have the infarction after day 14, after 2 weeks. This pathology may be something different from usual symptomatic vasospasm. And the aggressive removal of subarachnoid clot, ARSC, combined with continuous low-dose intravenous nicardipine, CLIN, is very effective. Symptomatic vasospasm, subarachnoid clot removal in major system is well controlled by ARSC with CLIN, regardless the age of the patient. Our result was 5%. The drawback of aggressive removal of subarachnoid clot is difficult technically, that we need training. The delayed infarction of distal territory of cerebral arteries after 14 days in elderly patient is a problem to be solved in the era of elderly society in the world, especially in Japan. So, in conclusion, aggressive removal of subarachnoid clot and continuous low-dose intravenous nicardipine is effective to prevent symptomatic vasospasm and DIND. 60,000 international unit urokinase in 500 milliliter saline helps to remove the subarachnoid clot in acute stage surgery to clip the ruptured aneurysm, as well as is useful to visualize the anatomy in the subarachnoid space for a precise surgery. Yeah, that's all. Thank you very much. Thank you for your attention.
Thank you, dear Rukaya. Beautiful, beautiful presentation, beautiful lecture, as we, of course, expected. So we really appreciate this effort. So I just want to, there's some questions. First, just a general question. What do you think the future, Rukaya, is of microvascular surgery in the era of endovascular coiling and stenting.
Yeah, it's a good point. Yeah, some neurosurgeon, not only neurosurgeon, the radiologist or endovascular surgeon says, the neurosurgery is disappearing. It's something a classic surgery, but still the surgery is available, especially for complex aneurysm, difficult aneurysm, and failed endovascular failed aneurysm. We need something revascularization to clip the aneurysm or to trap the aneurysm to perform the parent arterial occlusion. You need the revascularization beforehand. And to do this, the micro anastomosis revascularization skill is necessary, absolutely necessary to save the such an unfortunate patient. So the role of a neurosurgeon is becoming much more heavy in the future. So this may be said. It is said. It may said. It's terrible. It's not happy for neurosurgeon. But I don't think so. It's the quite big chance for neurosurgeon, especially young guys, because the neurosurgeon who can perform such a excellent surgery, who have the good skill, is maybe become rare, and it's very worthy for the people, for the patient, for the world. So to have a continuous training, big training, hard training, it makes young neurosurgeons' future happy, bright, I think.
Yes,
Like
I
that.
agree. I agree with you, Professor Tanakawa. I've had people who told me you're the last of the dinosaurs, but I don't believe I'm the last of the dinosaurs. I think we're creating a whole new generation in the future that are going to be master microsurgeons. There is a role for this in the future, and maybe indications may be different and maybe more limited. But as you said, it is needed.
Yeah.
If you see heart surgery, they have not too many people in many countries who can perform beautiful bypass, cabbage bypasses, because the impact of the stenting of the coronary arteries. So when a person really needs a good cabbage, sometimes you have to look for good people who can do this, and there are less and less. We do not want this happening in the field of neurosurgery. We got to be careful as to how we evolve ourselves, having learned lessons from other specialties. So I think that's very important. We have a number of general questions from some of our students and so forth. One question is about post-operative care. What do you tell your patients, Professor Tanakawa, about once they leave the hospital, how long after a bypass surgery or aneurysm clipping, how long they have to stay home, and how long do you limit their activities for?
Not only the microanastomosis, but aneurysm surgery. The usually patient discharge at 10 to 14 days after surgery. And yeah, of course, if something complication happened, the admission period is prolonged, but usually less than 2 weeks in Japan. Maybe it is longer than that of in US. You have a much more shorter admission period around the 2 to 3 days. But in Japan, with very strong insurance of the medicine, it can be covered around 14 days, no problem.
That's very nice. That's very nice. Well, we would like to thank the professor for such a deep discussion and a presentation for us. It's been a great session for us. Rukaya, please stay with us for a second. I'd like to thank our team in Mexico City for putting this together. If you go ahead and stop the international transmission so we could just say goodbye to the professor and so forth.
Yep.
Hirama, let me know when we're off the transmission.
Ya. Ya, doctor, ya.